Hello, you've got me again, unfortunately, because Angela is poorly. What Angela had done was she talked about she talked to us about some themes that she would like to present. So I'm going to talk a little bit around some of those themes. So forgive me in that I'm talking about somebody else's slide who you can't see. Some of this will echo what we've already talked about a little bit beforehand, so I won't labour and spend a lot of time talking, but one of the things specifically that we understand is that for the GPs, brain tumours and central nervous system tumours are very rare. Often they might be seen in childhood and young adults, and for that aspect it does mean that, as we previously said, a GP may actually only see a person with a brain tumour once or twice in the whole of their practice, and therefore 2 or 3, in a whole of a career, then that actually makes it quite difficult, and to have that specialist knowledge and to know how to refer and when to refer the people. The other thing is that, as we've already heard from Ali and from Helen, that symptoms are often very vague and possibly, multiple etiologies, and who do we refer to, and how does the GP make those referrals, and also the potential challenge that there is in relation to waiting times. So an example that Angela was talking about was the fact that if you've got a patient who comes to you and you think that there is a neurological problem, the question might be, well, how do I refer that person? Because I think it's something that they do need to be seen more quickly than possibly the 18-week wait. So therefore, what GPs might actually do is refer through accident and emergency, because that's their only source of how to get the patient into the system. Once the patient is diagnosed and sent to the specialist centre, there is that issue of the GP can often feel marginalised and out of the loop in relation to the communication and knowing what's happening with the patient and how to interact with the patient when they're discharged from home. And so, that sort of underlines the communication challenges that there are between primary and secondary care, and especially if the patient has gone into a specialist centre that might actually be quite a long way from where they practice as a GP. And also, it's that specialist interpretation of the scans and what that means. Because, interestingly enough, what we have heard is that GPs have found it more informative that now that the letter that goes out is something that is sent to the patient, it's said in a simple way that is easy to understand. And therefore the GPs enjoy that fact, that it's more informative to them because it's not their area of expertise. We know that there's often a delay in diagnosis, and that can be because of lots of different issues. And some of the patients that actually come through accident and emergency may have never been to see their GP before. So it isn't that the GP has missed the diagnosis. It's actually that the fact that they presented with something that was very acute. And certainly the patients, when we did the patient interviews and the mapping events, a couple of the patients had actually come through having their eyes tested. So someone gave us an example of where actually they'd been to see the optician, and in fact the GP had sent them to see the optician because they'd been to see the GP on several occasions, and the GP was a bit concerned that it might be related to their vision. They went to see the optician, and the optician said, actually I think you've got something that could be quite a big problem for you here. And if you start to vomit within the next 24 hours, you don't go see anybody, but you go immediately to accident and emergency. And in fact, the person did start to vomit, and they went through accident and emergency, and within a period of 24 hours were diagnosed with a brain tumour that was the size of a grapefruit. You know, and so what we mustn't underestimate is that people come through different access points. Also, the challenges for GPs are related to the symptoms. So some relate to personality changes, the fact that it's management of patients who have convulsions and acute problems. Also, the challenges that there are in talking to patients about how that is affecting their life. So it's not only the medical management of those symptoms, but also talking to someone about not driving anymore and the impact that that has to them for their lives, and talking about relationship issues, especially when quite a lot of the patients will have young families and how to manage that, and you will hear more about that later. Mental capacity issues and how to manage that, and how to manage that for the patient and for the carer, and the significant problems and challenges that that brings. Communication issues, you know, sometimes it's about an inability to speak, but also it's about an inability to read or to see, you know, to understand what's written on the page, and to understand that and the significant impact that has for patients and families. But also, if you're giving information out to patients or you're telling them things, what can they take from that and what can they remember? Significant issues around mobility, lifting and handling, those kind of issues, but also how that impacts on their lives. Are they able to walk? You know, do they need help? Do they need enablement in relation to that? The use of steroids to control their symptoms, certainly around the significance of cerebral irritation and fits, and GPs aren't necessarily happy to use high dose of steroids. And there's a bit of a challenge when patients are on a reducing dose of steroids and they might be admitted because of an acute problem, and the steroids are put up again, and managing that between secondary and primary care. How to look after someone if they're not actively dying, and how to manage them at home, because sometimes the services might be related more to acute end-of-life care rather than actually enabling that person to manage at home. And what does that mean? Where might be the most appropriate place for them to be cared for, whether it be the hospice, it might be actually attending day therapy at the hospice. So managing all of those issues, and certainly around end of life and the impact that has significantly for the patient and their family, but especially when some of the patients who are diagnosed with a brain tumour actually may be very young, and therefore managing them and the end of their life will be very challenging. An example is sort of like symptomatic management, but you will hear more from that later from the clinical nurse specialist team from York. So just a few things to sort of consider, but hopefully you've got a bit of an idea from the perspective of the GP. So thank you.